Good morning. We're going to get started. If you could please take your seats. So my name's Kim Bimestefer. For those of you I haven't met, I'm the Executive Director of Healthcare Policy and Financing. Michael and I are going to start with a couple of introductory and opening comments and then go right into the material. We'll take our time moving through steadily the material so we're clear. We'd ask you to hold your questions, and then we're planning on at least an hour for your engagement and questions. So there should be plenty of time. So with that, are we ready?
Yep.
Okay, so I'd like to start off by saying thank you to Representative Roberts, to Representative Donovan, to Representative Catlin for crafting and for sponsoring this bill, and for entrusting our departments, the Department of Insurance and Healthcare Policy and Financing, for engaging with stakeholders and for bringing through a draft proposal. So thank you to the representatives for their leadership. And I'd like to personally thank our office at Healthcare Policy and Financing for the very early mornings and the very late nights for working through and bringing this to fruition. And thank you to the stakeholders. Michael will touch on that a little more thoroughly, but just from me to you, we sure do appreciate your engagement. That's what's making this so amazing, this process so amazing, that as you see and review the draft proposal and hear our words, we hope you see a little bit of yourself in this, and the commentary and the good ideas and concepts that you brought forward. As you listen to this draft proposal, I want to remind us of why we're here today. So I want you to set a vision for your mind. I want you to think about the 18% of Coloradans, according to the Colorado Health Institute latest survey, who couldn't get care, chose not to get care because they couldn't afford it. That's nearly 1 in 5, or 20%, nearly 1 in 5 of Coloradans are sacrificing care because they can't afford it. That's why we're here today, and that's why we have this draft proposal. I want you to think about affordability and the stakeholders who said, please include more than just premium rates in affordability. Think about those out-of-pocket costs, which then drives back to the 18% not be able to get care. I want you to think about the families struggling that have to make a choice of whether they send their child to college, whether they pay the rent, whether they cover overhead, whether they have the life they want to have in order to pay for health care. So as we work through this, please keep those folks in your mind, because that's what it's about. It's about Coloradans. It's about meeting the need and hearing the voices. And I want you to think about last that we have about 19.5% of the small group market, those individuals across the country who work for a small employer that still don't have coverage. That's far higher, 3 times higher than our state's uninsured rate. So I want you to think about the voices of small employers who have said for 10 years in a row that healthcare costs are their #1 concern. And that aligns with Coloradans who have said the cost of healthcare is their #1 concern. So as we listen to the draft proposal, keep that in your head. That's what we're trying to solve. And then I would encourage you to recognize it's a draft, which means we need to craft and refine it together as we come through the due date of November 15th. And with that, I will turn it over to Michael.
So thank you, Kim. I'm going to start with a few thank yous of my own as well. So my team was awesome as we put this plan together. Kate Harris came on about 6 months ago, and we wouldn't have been able to get this done without her. Kyle Brown, who isn't quite here yet, came on about a month ago, his first week on the job. We told him he had to start writing, and he said, what am I writing? Casey Wolf from the Office of Saving People Money on Healthcare was vital in getting this all done. The Res Meinhold was awesome in helping us through the meetings. And then Vince Plymell, who is someplace in the room, had to actually go with me and drive around the state and listen to me drone on and on about boring and not uninteresting things. So without them, we wouldn't have gotten here, so this is a huge thank you to them. But with that, I really want to start on kind of picking up from where Kim left off. And talking about the people of Colorado, right? And what we heard from everybody throughout Colorado as we went on this journey. That's what really framed out what you see, what you all probably saw in the report last night, what we're going to be talking about today. And as I went around the state, one of the things that I constantly talked about, one of my themes, was the unique opportunity that we have in Colorado right now. This unique time that we have to truly transform our market, our healthcare market. And I think that is clearly shown in the last legislative session. So when you think about what got done in the last legislative session, Kim got the hospital transparency bill through, she got drug importation through, Representative Roberts got this bill through, we also got the drug insulin bill through, we got the reinsurance bill through, we got that stood up, we got our purchasing alliance law transformed so that we can make it easier for things like Peak Health Alliance to really change the marketplace. Some of those bills, the surprise billing legislation got through, which was transformational. Some of these bills took 3 years to actually get to the point where we are today. That's 3 years. 3 years of painstaking conversations. Why I highlight that is if we had gotten one of those things done, 2 of those things done in this legislative session, it would have been a huge victory. If we had gotten 3 or 4 of them done in the full 4 years of our term, it would have been awesome. But all of that happened in the first year. And that happened because of the partnership that is in this room, because of the partnership in this room, because of the partnership that we had with legislators. All of those bills had bipartisan support. And we're hoping and we're asking for partnership with this too today. So with that, let's get started. So here's the agenda. As Kim said, this is going to be this agenda we're going to work through in about an hour. We're going to go fast. And then we're going to ask for you all to tell us what you think. We're going to have some back and forth, I'm sure. Hopefully there aren't too many rotten tomatoes thrown at us. But it's going to be a good conversation. And that's what we want today. And that's what we want for the next 2.5 weeks. We put this draft out there with the intent that we want to have a conversation for 2.5 weeks so that we can then use your feedback to put together the final product. So, overview of the process. We went around the state starting May 29th. So, the session ended about 2 weeks later. We had our first stakeholder meeting. We had our first stakeholder meeting in Denver. We had 2 meetings in Denver. And then we traveled around the state to 12 different spots. And we heard from people. We heard from people about what they wanted in the plan, what they didn't want in the plan. And as Kim said, that colored everything that you're going to hear today. We also got 42 letters from you all. 42 letters of things that you liked, things that you didn't like. The vast majority of them were in support. We had 1 or 2 that were opposed. But for the most part, we heard from you about what you wanted in this plan and what you didn't want in this plan. And then finally, we had 6 different presentations up in Keystone. 6 different presentations from very different entities, again, about the different things that you did or you didn't want in this plan. All of that went into us putting together what you're going to hear about today. So, key aspects of the state option proposal. At the very highest level, what we're asking for is a public-private partnership. We want this to be a public-private partnership that we can put into the marketplace to put a product together that is going to be sustainable and that will last into the future. The top line here is the most important piece. We expect, based on our actuarial analysis, based on the plan that we put together that you're going to hear about today, that we'll have a 9 to 18% premium decrease for folks in the individual market starting January 1st, 2022. That's when we're planning to launch this plan. So that's 9 to 18%. We're going to talk a little bit about the pros and cons and the different ways that you can get to that 9 to 18%. But that's the top line message, is that we believe that we'll be able to save people in the individual market 9 to 18%. Plans are going to be administered by insurance companies and sold on Connect for Health Colorado. So the biggest reason why both of those are in play is so that we can make sure that we can get people their subsidies. So people in the individual market, as we all know, if you're below 400% of the federal poverty level, you're eligible for subsidies. We wanted to make sure that we brought that into this plan as well. We want to make sure that we provide that relief and we keep that relief in the individual market. There's going to be very low admin costs for the state, and we will not be bearing any risk for this plan. And that's key, right? We don't want to put together a plan that 3 years down the road when we have a bad flu season, as I think it was CBS 4, talked about it in their article, a bad flu season that could drive huge costs that we weren't planning for and the state bearing that risk. That is not what we're proposing here today. So we're proposing that the insurance companies fulfill their traditional obligation to carry risk, and that's the key component of this plan. The next piece, we are proposing that we will set reimbursement rates for hospitals. But we're proposing that we're going to set those rates at a level that will do 2 things, and these things are vital, and I really want to stress them, and you're going to hear us talk about them a lot today. As Kim would say, we're going to fiercely protect our rural hospitals. What that means we'll elaborate on, but it really means that we understand and we recognize that rural hospitals are different than our urban hospitals, than the hospitals in the Denver metro area in particular. And we need to make sure that we're thinking that through and being very logical about that. But we're also going to be setting rates at a level that we know and we believe will provide a healthy profit to insurance, to hospitals. And those rates, what we're proposing, are 175 to 225% of Medicare. So in that range is where we believe is the sweet spot. And we're going to talk about what that means. At 175% of Medicare, we're at the 18% premium decrease. At the 225% level, we're at the 9% premium decrease. So what we're looking for from you all over the next 2.5 weeks is your feedback about where we should be, where we should land in that metric. So that's going to be a key part of the conversation over the next 2 weeks. The last piece is part of maybe the piece that I'm most excited about, and that's the advisory board. I'm going to talk a little bit more about the advisory board later on, but really what the advisory board gives us the opportunity to do is continue this conversation that we've had for the last 4 months into November 15th, past November 15th, and as we start to structure this plan and build this plan. This is a really exciting component, so I'm hopeful that you all will give us your thoughts as we go about what we should put into that advisory board. Kim, I'll turn it back to you.
So what's covered? We heard from stakeholders, maintain the essential benefits, maintain more standardized benefits so we can compare. As we look to the future and have savings from this, there may be some ways that we can adjust what is not subject to deductible, so we can cover more in that pre-deductible state. That helps providers, that helps patients and Coloradans. It brings a lot of good value. So we heard you on what is covered. On the next slide, who is covered? So the initial objective is January 1st, 2022 for the individual market. As Michael said, through Connect for Health and as well as off exchange in the individual market. That's about 8%, 7-8% of the market. It moves a little bit on us. But starting there, again, that's the area where folks are most vulnerable, where they've asked for help. But in quick follow through, entering the small group market. Why those two markets? Because that's what the bill asked us to address, the individual market and the small group market. And again, when we hear about the small group market, we know that's their #1 issue. We also know that's where a significant portion of the uninsured populations come from. So we want to address those two markets with the small group market coming after individual. We also want to recognize that CHA and others asked us to move in a stair-step manner, to not take on too much at once. And the stair-step is also in response to that request from the industry to be thoughtful, to be careful, and this will allow us, this stair-stepping, to do that. From a quality perspective, we're excited for a couple of placeholders to be able to influence quality. One is the advisory board that Michael talked to, but that advisory board that should represent the interest of stakeholders, so the provider community, doctors and hospitals and others, the advocates that represent as well the consumers on their brokers and insurance carriers, to be able to collaborate together and to say, in the best interest of Colorado and Coloradans, what are those levers that we want to pull to achieve what objectives in the areas that we want to definitely drive improvements in quality? So we might together, as an industry, together say, we have had enough of this opioid crisis. We're going to do everything we can to stand together, to have a collaborative process to keep driving the proper utilization of opioids for the best interest of Coloradans. So together, we can identify those areas where we want to focus to make the best impact that we can. And how do we do that then? What's the lever that we use? It's value-based payments. So value-based payments can be both to providers, and value-based payments can be to carriers who hit metrics that we set together. We're very excited for how we can use these levers to drive quality in the industry. So if we consider Michael's objective, we want to maximize the infrastructure that he talked about in order to have the best public-private partnership. Michael hit on a few. I'm going to hit the first 3 bullets. Healthcare policy and financing and DOI to together public-private partnership to lead this to chart goals, to monitor providers and carriers, to maximize the existing skill sets in both of our organizations, and to pull together the best talent, the best skill sets, so that when we see the carrier's values, can they craft programs that help get people well? Can they answer the phone right around the time? Do they take risk well? But where there are areas where we want to see improvement, how do we bring a public-private partnership to say these are the areas where we want you to focus, to do things differently than you did yesterday, to respond to the demands of stakeholders? And we think we can bring great value there. When we look at DOI and the regulatory authority, this is a commercial product, so they have regulatory authority over the carriers. We are excited and pleased to pay brokers a commission per belly button per month or per participant per month payment. That came as recommendations from the broker community. You might remember A.J. Earl bringing forth one of the presentations on July 26th. We also had a consultant that is, I think one of you would all agree, is one of the most trusted advisors coming out of the broker community. Bill Lindsay did a thorough report for us and made recommendations on paying at a per member per month. And the brokers as well stood up and said, hey, we need to be part of the equation. So we're pleased to continue that wonderful relationship and know that by paying a per member per month allocation, that the interest, that the incentives are aligned, that we want brokers to always act in the best interest of consumers, and that per member per month allocation helps us do just that, to put the consumer in the center so they're always getting the best advice. And again, as Michael hit the next three, I won't hit those. Let's turn to the next page. Many of the advocates and stakeholders were passionate about how about if we build this infrastructure on the Medicaid chassis? What would that look like? Medicaid is already the largest health plan in the state. It covers 1.3 million people, 1.3 million Coloradans, 21 to 22% of the population now higher in bad economies. As well, the population in Medicaid churns. So in every couple of years, we're hitting more like a third of the state. You go 3 to 5 years out, we're hitting 40% of the state. So the churn through Medicaid is incredibly meaningful. So a lot of people said, well, why don't we build this on the Medicaid chassis? It makes a lot of sense. So I want to say first, to all the stakeholders and advocates that had that view, thank you for your confidence in healthcare policy and financing. Thank you for your trust in what we do as a not-for-profit organization that builds its whole mission around serving people well. But with that latter statement, I want to underscore the vulnerabilities of the people that we serve and how important it is to focus on them, to focus on doing that well. And so the fact that we're not building this on the Medicaid chassis, I want those who every day rely on us, sometimes for their very life, to know that we are focused. And you are who we serve as our primary objective, and we will continue to serve those who rely on Medicaid every day. Some of those are in transition. There's a mother who loses her child may need to be carried through a very short time when the grief is so bad she can't put one foot in front of the other. Breadwinners who come home after being given a pink slip and their entire industry has been shipped overseas. And we need to carry them through a short period of time until they find new skills and they figure out the new career next step for them. And we're proud of that. But there are also about 74,000 people who have waivers through Medicaid that are disabled, sometimes intellectually and developmentally disabled, physically disabled, chronic conditions. It's important to us to remain focused on that population. And I hope that those folks say thank you for that, and they are reassured by that decision. Two other reasons are operational and financial. So operationally, Medicaid is not tooled to be in the commercial space. We don't have a license. We don't do a lot of the standard things. We don't pay brokers. We don't collect premiums in the same levels. We don't have eligibility mechanisms that sit in providers' offices in the same way as counties do that for us. So how we are set up and our relationship with the federal government is very different than the infrastructure that we would need. We would, in essence, need to build an entire insurance company running parallel to Medicaid. And I follow a strengths-based leadership approach. Many leaders do. We want to respect the carriers and the wealth of talent and infrastructure that they have, and we want to maximize that infrastructure versus trying to build a parallel infrastructure at, by the way, the expense of the state. To say a secondary expense of the state, to do this, we would have had to ask for tremendous reserves in order to handle what's called a terminal liability reserve and a claim fluctuation reserve. I've worn those hats in the future. As Mike said, claims go up and down. It's as much science as art, and the carriers have the financial integrity and ratings to be able to manage that claim fluctuation, we would have had to ask the General Assembly for all of that money, and that would have been a pretty big hit to taxpayers and others. So trying to use everybody's strengths, we've made the decision that we have, and I will turn it over to Michael to cover the next slide.
So now we're going to talk a little bit about affordability, and then we're going to transition into the rate setting conversation. But with affordability, so what we're focused on is really two different groups of people in the individual market. We're talking about people over 400% of the federal poverty level. So that means people that are, if a family of four, we're talking about a family income of about $98,000. For a single individual, we're talking about $48,000. So it's right in the heart of our middle class. It's also what you hear talked about quite often as the subsidy cliff. And that's what we're showing you up here with this slide. So the people above 400% of the federal poverty level, that heart of the middle class, the economic engine of our country, they don't get any help purchasing their health insurance. When you hit that 400% number, you no longer have subsidies. You no longer have help from the federal government in order to afford your health insurance. These are the only people in all of our health insurance markets that don't have any assistance. If you're on Medicare or Medicaid, the federal government's helping you out quite a bit. If you're below 400% of the federal poverty level, the federal government gives you subsidies. We're going to talk a little bit about helping those folks a little bit more too, because we, as you all know, for everybody that's looked at the CHAZ survey that came out 2 or 3 weeks ago at this point, the biggest portion of our uninsured population is in that 200 to 400% federal poverty level cohort. So we need to help them too. But this middle class is really a big focus of what we're trying to get done here, right? This is the 9 to 18% that these folks are going to really feel that 9 to 18% in a really meaningful way. So affordability, what this includes. As we've touched on throughout, we kind of asked a whole set of questions as we went out. We had a stock set of questions and a stock set of talking points that we tried to work through. Affordability was clearly one of them. We've got a definition in the recommendation that I encourage you all to read and give us feedback on. But what I want to talk with you all about today is what we heard when we were out at those 14 meetings about what affordability meant to people, what folks wanted us to focus on when we were having conversations about affordability. And it was these three things that we constantly heard every time that we went out. Obviously, the first two are kind of high level, but they're the obvious ones. Folks are concerned about how much they're paying for their premiums. They want premium relief. And that was true universally. Folks are obviously very concerned about their out-of-pocket costs, their deductibles, their co-insurance, their co-pays. Those have increased through the years too. And there's a real focus and there's a real desire for this plan to actually address that. We do that, and we have the potential to do that through the standardized plans that Kim was talking about. The standardized plans will give us an ability to level set premiums, level set deductibles across the board. That's going to be vitally important for consumers. But this last one was a little bit surprising to me that we did here at Universally. And I do think it's a recognition of the work that we've done over the last 3 or 4 years to really try and educate people about what is driving their premiums and their deductibles. It's the costs of care. And people universally, when we were out and about and throughout Colorado, wanted to talk about and wanted to urge us, and did urge us, to do something about the underlying cost of care, because there was a recognition that if we didn't, we weren't going to be able to get to that 9 to 18% point. If we don't address the underlying costs of care, we're never going to be able to actually achieve any sustainable relief for Colorado consumers. And that's what we're here today to talk about. So, how are we going to get to this affordable place? We've talked about the rate setting component. That's up here too. We're also going to do a few other things. We are increasing the medical loss ratio. Our recommendation is to increase the medical loss ratio for this product in the individual market. So the medical loss ratio in the individual market today is set at 80%. What that effectively means is that insurance companies have to spend 80 cents of every premium dollar that they have come in the door on the cost of care. So 80 cents they have to pay out to hospitals, to providers, to pharmaceutical companies. Our recommendation is that for this product in the individual market, we increase that to 85%. That will provide more relief for consumers. The hospital inpatient and outpatient, we want to partner with hospitals to get to a more efficient level. That's what this is all about. This is about a partnership. But we need that partnership in order to do these things. Then this last one, there's 3 components for insurance companies that we're going to be talking about today. 2 are on this slide, and we've got 1 more coming. But the PBM rebates, we are going to recommend, and we are recommending that those be passed through to consumers, either in premiums or in cost shares, one of the two. We don't get into detail in the report about which one it should be, so we welcome your thoughts on that point as well.
Can you, before you go, can I add a little?
Sure.
So I want to add a little color to this slide. I want you to think back when the individual market on exchange was developing and the ACA was moving through, and the carriers were literally, and I was wearing a hat as the president of a big company in this state, of not knowing how you're going to put a rate out there and you don't know what you're going to get. And that was a little nerve-wracking. So when these rules of 80% and 85% were set up, it was a very different time and place. I want to compliment Commissioner Conway on the stability in this individual market. I want to compliment him on pulling together carriers, maintaining carriers, having single-digit rate increases at a time when other states would give the right arm for that. So when you see this adjustment of an MLR, I want you to contrast yesterday to today with a more predictable market, a more stable market, one of the healthiest markets in the country with very strong participation. Commissioner Conway didn't lose any carriers coming through the last session, so it's a very different time and place. I also want to remind you that the MLRs are set at 80% and 85%, or the inverse 15% and 20%. The average overall retention for carriers across the country is 13.5. 13.5. That is below both the 15 and the 20. So again, we're asking everybody to come up to the table and to be a participant, to figure out what they can do, not to fight for what they don't want to do, but to figure out what they can do, to rise up and to be part of the solution. So this is an avenue, and broker commissions are outside of that for a discussion, and let's ask what we can do together to lower prices for consumers. And on that last one with prescription drugs, there's $160 billion that moves between manufacturers of pharmaceuticals through to PBMs or insurance companies, whoever's in control at this point. And in a perfect world, those move through the system to offset and reduce the cost to employers in the same way they would in Medicaid. Medicaid pays a fraction of our costs, which means taxpayers pay a fraction of the cost because 100% of those rebates go to offset our costs. For us, we pay less than 50 cents on the dollar because of rebates. So I want to recognize that we're just asking this public-private partnership to follow some of the practices in the best interest of consumers, and where the incentives in the industry are misaligned, that they're not in the best interest of the consumers, those incentives through rebates push the most expensive, highest cost drugs. That is not in the best interest of a well-priced market. So those are examples of areas where there's opportunity with the MLR and where we're addressing misaligned incentives on rebates.
Great thoughts, Kim. So affordability, we could save even more with federal approval. So as you all know, we just got approval for a 1332 waiver. We'll use that 1332 waiver to establish our reinsurance program. We don't need a 1332 waiver for this program, but we are going to ask for one. And we're going to ask for one to touch on that 200 to 400% portion of the population. The federal poverty level of 200 to 400%, that cohort is the biggest portion of our uninsured rate, exists in that cohort. So we want to do something about that. This ties directly to that 175 to 225% of Medicare number as well. So when we're reducing premiums, so when we reduce premiums either 9 to 18%, that will have a direct impact on how much money we can get through a 1332 waiver. If we reduce premiums at 9%, we're projecting that we can get about $70 million from a 1332 waiver. If we reduce premiums at 18%, at 175% of Medicare, we're projecting that we can get about $130 million through a 1332 waiver. Then we can use that money to do one of these three things, or maybe all of these three things, some portion of a combination perhaps. But from my viewpoint, we should be focusing on that 200 to 400% portion of the population so that we can further drive down our uninsured rate. The other thing, so when we talk about out-of-pocket costs, when I talk with the hospitals, when I talk with the hospital association, or when I talk with FQHCs, one of the biggest frustrations that they have is their uncompensated care of out-of-pocket costs, deductibles, coinsurance that they aren't actually collecting. This can help exactly with that piece, right? If we're putting this money, if we get a 1332 waiver and we get that $130 million and we provide relief for consumers on their out-of-pocket costs so that we reduce deductibles, that helps exactly with that problem. But there are the other pieces up here too, right? There's one of the things that we heard constantly around the country is that, or around the state rather, is that people want dental benefits, and they want dental benefits to be a part of this product. We have to find a way to pay for a dental benefit. This could possibly be a route to do that. And then we can just fundamentally expand tax credits. So expanding tax credits for people in order to help them purchase their insurance. So why set hospital reimbursements? So these two data points are really kind of, I think, a key reason why we are having this discussion. When we look at the Denver area hospitals, that their profits grew by more than 50% over the last 2 years, and at the same time, nearly 20% of folks, 1 in 5 people, can't pay their medical bills. Those two things don't jive with each other. It's a reflection of a broken system. And those numbers aren't going in the right direction either. It's not that we're getting to the point where a smaller and smaller portion of the population is telling us that they can afford their medical bills. The opposite is happening. And profits in the Denver metro area are going up for hospitals. That's why we're having this discussion, folks. That's why we're asking for this partnership. It's because we want to solve for this problem. And we have to solve for this problem. We know that this is going to be a difficult conversation, but we promised you when we took these jobs, I promised you when I took this job, that I wasn't going to shy away from these difficult conversations. And that's why we're here today. So a few more data points. As Civic, as we all know, the Center for Improving Value on Healthcare, a recent report that they had come out showed that we have huge variations amongst prices at hospitals. Huge swings without any real explanation of why that's the case. 400%, more than 400% swings from hospital to hospital for the exact same services. And there isn't necessarily any connection at all to quality when we have that, when we look at those numbers. We don't have any set standard in the state, really in the vast majority of the country, any set standard for hospital prices. As Kim was talking about earlier, the Affordable Care Act really did do that for insurance companies. That 80% MLR, that 85% MLR, that really did set the benchmark for insurance companies. We haven't touched it for hospitals. So we have to get to something. In order for us to build a more rational healthcare system, we have to have this conversation. Stakeholder feedback, I touched on it earlier, but on every stop, whenever we talked about this, whenever we talked about affordability, stakeholders urged us to do something about the cost of care, because there's a recognition that if we don't, we are going to long-term fail at this. We will not be successful if we don't approach this and we don't solve for this problem. So that's why we're having the conversation. And then the last piece, I think, is self-evident, as we've seen around the metro area in particular, that as hospitals have merged, consumers have lost their leverage. We've seen that in the prices going up and up and up. Every time hospitals merge with each other, hospitals get more leverage, they bang against the insurance companies, and they demand more. And the consumers are the one that pay that price. It's not the insurance company. It's one of the fallacies in our system that as we demand more from insurance companies, that there's a belief that insurance companies just pay that. That's not true. They pass it through to us. So if we don't do something about this, we're never going to be successful.
So I'm going to ask Michael to help me on this slide. I'm going to explain it first. On the y-axis, or parallel to the walls, are averages of reimbursements across the country against Medicare. So relationship to Medicare. On the x-axis, or parallel with the floor, those are states that also have an all-payer claim database that we can compare reimbursements from hospitals. And so the request, as Michael said, between 175 and 225 is not out of line with the rest of the country. It's actually exactly in line with the rest of the country. Now, some of the folks that were speculating on what would this state option be were assuming reimbursements, and reports have been produced in the Colorado area that have said what would happen with hospitals if a state option. I want us to push all those reports and statements up to this point to the side. They're based on speculation, and I want to invite you to understand what it means to set reimbursements between that 225 and 175. If you look at that flat red, if you look at the squares that go across almost parallel with the floor in the middle there, that is the average of reimbursements for outpatient and inpatient hospital. The triangles are outpatient and the circles are inpatient. So if you look parallel of those squares sort of all lined up, they're coming across to about that 225 and below reimbursement. So what we're asking of our hospitals is to compete more effectively with other states on where they're priced. We are not asking for our hospitals to do anything different than compete with other states with where those consumers are paying for care. And that's a critical aspect. Push all of the misinformation out and recognize what we're asking for. We also want to underscore that the approach we're taking at the request of the industry is a multi-year approach. So the pace at which we get there is a matter of good dialogue and collaboration between all of us on what it takes to move from yesterday to tomorrow. But I want to recognize that the triangles up top are partially a reflection of the industry being more focused on inpatient and right people, right place, right price. And there's a lot of cost control, utilization management around inpatient, much less around outpatient, and the price around outpatient is dramatically higher than inpatient as a reflection of Medicare. And I want you to also look at that blue bar that's to the right. So Colorado is the 6th state from the right. There are only 2 triangles that are more expensive than us in outpatient. That deserves a pause. There are only 2 triangles of all the states where we can track where outpatient is more expensive than our state. And both of those states are having conversations as intensely as we are. So we're asking those averages to come down to the norm. We're asking our inpatient. There are 3 states that are more expensive than we are in inpatient, only 3. We're asking us to move to the norms. Now, this is a big deal because if there were hyperbole about what does this do to the workforce and what should we do, I want everybody to recognize this should have no bearing on workforce. None. We're about to hit profits and areas of opportunity where reasonable reductions can take place. There should be no bearing on workforce in order to ask Colorado over a period of reasonable time to get to a competitive point in pricing to be able to compete with the rest of the states. We're the pioneering states. We can do even better than that. Michael, do you want to add any color to that?
No, I want to really stress that last point, right? When I think one of the most important pieces of information on this chart is that a number of states, a number of very high-cost states, right, are far below where we are as a percentage of Medicare. And they don't have work shortages in those states. So as Kim said, there was a lot of misinformation that was put out about what people thought that we were going to possibly recommend. What I asked you all as we had the conversations around the state was to check your assumptions at the door. And I think we're showing you today why we asked you to check your assumptions at the door, but I need you to check that misinformation at the door too. Because there's no reason, as Kim said, there's no reason that if a state like New York can be down where they are as a percentage of Medicare, why we can't be there too. Why us as a pioneering state, as Kim said, us as we have always led the way on healthcare, why we can't be just as competitive.
I want to add, before we leave that, all healthcare is local, and these are state averages. We want to underscore to the rural hospitals that we will fiercely protect you. Rural hospitals, critical access hospitals, we will fiercely protect you. Now, there are some critical access hospitals that are in some of the more well-off mountain communities, resort communities, that have opportunity to reduce their prices as well. So not all critical access hospitals are equal either. So all healthcare is local. The time for this in this next 3 weeks to discuss how do we get from here to there while fiercely protecting and ensuring the sustainability and the thriving of our rural hospitals and communities while we address the opportunities to lower costs in resort areas, to stabilize those rural hospitals, and to recognize the profit opportunity to lower prices in the Front Range. All healthcare is local. So let's learn from the past as we look forward. So the chart on the left says that through the ACA and the provider fee, we put a whole lot of money, federal money, into the system, taxpayer money that went to our hospitals. So 2 things went on in 2009, passed a bill, started in 2010, that our department has the privilege of being healthcare policy and financing. Some of the financing is John Bartholomew in the room, our CFO. Under him is the monies when the hospitals bring about $600 million to the table, goes through our department, goes to the federal government, gets doubled, comes back, turns into $1.2 billion, and we use that to make up for Medicaid shortfalls. Medicaid shortfalls in payments, because Medicaid doesn't pay as much as commercial payers. We pay and target Medicare. So that provider fee reduced unfunded liabilities from the hospitals. It reduced their uncovered debt, if you will. So their debt went down. If we then look at the ACA came through, and we went from a high of uninsured rates of 15.8%, 2013-ish, to 6.5%. 6.5% has been in place since a couple of years after the ACA, and it has stayed pretty stable. The last Colorado Health Institute report just released last month said that uninsured rate is still about 6.5%. There's probably a little noise in there because the public charge issue came after some of those surveys. They're relooking at some of that. But the bottom line is that 6.5% reduced charity care by the hospitals. People that were yesterday were uninsured, came through the doors and were insured. And that reduced the charity care and the debt of the hospitals. So tremendous reduction in debt, tremendous increase in revenue coming into the hospitals. So with that, there was a strategic decision that could have been made. Do we reduce the cost shift to employers and consumers in the commercial market as debt and charity care is going down? There was testimony in 2009, the Hospital Association, that said, if we push this money into the system, we will reduce the cost shift to employers, and the bottom line is that did not happen. There is an opportunity to ask our hospitals to have better strategic decisions going forward between the boards who represent the interests of the community and the CEOs that represent running the institutions of our hospitals. And our ask is to have grace, to give them time and the wherewithal and the maneuverability to change. Change is hard. We're asking them to change. Change is hard. But we want to put forth that change can be done just by moving to more reasonable profit rates that were just fine in the past. So if we look at since this took place, hospital admin costs are rising at double the national average. Construction in the state, there's 3 ways to measure it. It's either 1, 2, or 3 is the most common and frequent. Revenues are up 76% since 2009, and hospital margins have increased 250%. On the next page, I want to illustrate that this trend is continuing. The Allen Baumgarten report just issued and just reviewed for 2019, looking at 2018 and 2017, reviewed 27 of the Denver area hospitals and the profits for 2018. These were the findings. $2 billion in profits was hit for the first time in the aggregation of these 27 Denver area hospitals. The $2 billion in profits compares with 2016 of $1.3 billion. That's more than a 50% increase. So when you hear us say a 50% increase, that's the calculation of where that's coming from. So when we hear a rhetoric of this might be a workforce shortage, a reasonable person would say, no, we can go back to prior profit levels and still have plenty of room, and even perhaps a raise for our nurses. So if the hospital prices grew at 57% faster than the national average, and the current profit margin is 19.3% for those Denver area hospitals, there should be no impact to workforce. We're just asking to get to more competitive prices that compete with the rest of the country. On the next page, overhead has also increased. Michael touched on the mergers. We have had tremendous mergers in this state. We used to have 6 entities representing 23 hospitals. We now have 7 representing 41. UC Health has grown to about 10 hospitals, Centura to about 17, Banner to 3, now 4 with the most recent acquisition in the last month. If you look at the increase in overhead administration, economies of scales and size should bring efficiencies. It shouldn't bring an increase in overhead of this regard. So if we have profits going up and we have expenses going up, and I'll quote last month the release by the Hospital Association saying 46 cents on every dollar went to overhead and profit. I'm going to give them grace to potentially change that. I'm not sure of its accuracy, but we can all agree there's opportunity to better control expenses and to have a more reasonable profit margin. Now, I want to make sure there's clarity. You can hit that next slide. It might seem we're throwing stones. I want to underscore, we're not throwing stones. What we're doing is making sure the facts are out there that when we drive to just compete on price, paralleling other states of where the workforce is strong, the economies are strong, the healthcare market is the same as a percent, that we can do the same thing as other states without impacting workforce by just asking our hospitals to be in partnership, and then to recognize that the journey they're on is difficult. that we have to give them grace and time to change. We need to make sure they're part of the conversation, to work in collaboration to help us get from here to there in the best interests of consumers, of Coloradans and small employers, in partnership with carriers and the provider space. Michael?
So on that partnership front, you've heard us say that word a lot, and we are striving to have that partnership, but we also recognize that there is at least a possibility that there may not be partnership in play, that our hospital systems may not want to participate. If our hospital systems refuse to participate, then this won't work. Everything that we're trying to achieve will fail, and that isn't going to be acceptable. So what we are recommending in this report is that if that is the case, that we have the tools to mandate hospital participation in this product and to see these people, to see these folks in the individual market. I also told you that we was going to come back and talk one more time. There were 3 things that we were going to ask of insurance companies in this partnership. The first 2 we've already talked about. This is the third. So going into next year, we're going to have 22 counties, up from 14 counties with only 1 insurance company in the mix. That's unacceptable. So what we are recommending in this report is that any insurance company in our major medical fully insured markets that has above a certain threshold of enrollment or market share would be mandated to offer this product as well in the individual market. That would bring more insurance companies into the marketplace. It would provide more competition, which was a key part of House Bill 1004, was that we had to find ways to increase competition. But we have to find ways, more than just increasing competition. We have to find ways so that when we solve for these 22 counties, we don't wake up the next year and we have a new 3 counties that are just down to 1 health insurer. This has to be a sustainable fix. Everything that we're talking about with you all today is about sustainability, is about putting together a sustainable market product that will be able to go into the future so that after Kim and I leave, somebody else doesn't have to start all over and fight this fight again. And then the last piece is that we do want, and obviously as I just touched on, we want multiple carriers in every county. So, protecting employers from cost shifting. One of the things that we've heard quite a bit of chatter about is that if we do this, that there is going to be cost shifting to employers. That's unacceptable. First and foremost, what we talked about so far is that we're going to put this into the small group market after we successfully implement this in the individual market. That is the goal. In the period of 3-4 years, faster if we can do it, but most importantly, after we successfully implement this in the individual market, the plan is to put it into the small group market as well. And then if we see cost shifting to the large employer market, which we have the tools to monitor now because of the primary care bill last year, and we will be monitoring them now because of the tools that we were given in the primary care bill last year. If we see cost shifting to the large employer market, we are also recommending that this product be put into the large employer market. But we've also given tools to the employer market so that hopefully they can control this themselves. I touched on the Peak Health Alliance earlier. I touched on the consumer purchasing model, the alliance model that we've been putting forth, that we've been striving to expand across the state. There is every reason and there is every power for those consumer purchasing models in order to fight for and get the same rates that we are going to be very transparent about with what we put into this individual market product. So our hope and our desire is that when we are transparent, when we're showing the entire world of how we are building this product, how we are getting to a more sustainable place, that our employer market will be able to follow suit. So the advisory board. I told you we were going to come back to this because it's probably my most important and favorite topic about everything that we've talked about today. So the advisory board, as you see in the recommendation, is really a pretty blank slate. It's a foundation that we want you all to help us build upon. But it's really, like I said before, it's an opportunity for us to continue this conversation. It's been a great conversation for the last 5 months. It's been a difficult conversation as we go forward, but it will continue to be a great conversation. But as we build out this product, we want to hear from you all over the next 2.5 weeks, but then going forward too. We want to hear what you think should be in the standardized benefit plan. We want to hear from you all. We want an advisory board to help us establish those things. Kim touched on the value-based insurance design. We want partners in that. We want the medical society to come and help us figure out what should be in the value-based insurance design. We want a robust advisory board that can help us now and in the future to develop this product and develop this plan so that we can have a good, sustainable future.
So again, we want to thank all of you who have participated, and we want to thank the bill sponsors for challenging our departments to hit the objectives. Here are the objectives that they laid out. Can we identify a feasible and cost-effective state option? We are confident that this draft proposal has done that. Can we ensure affordability to consumers of various income levels? Yes. Can we minimize administrative and financial burden to the state? Yes. And can we ease the implementation? Absolutely. We're using the existing infrastructure. I want to commend all of you. This is a representation of your engagement, your ideas, and I want to inspire you. We have the ability together to do amazing things, to charter the course for the rest of the country to watch, and to do it in a way that's bipartisan and incredibly collaborative, that uses the gifts and strengths of every part of the industry, from the all-payer claim database that helps us understand information, to the Connect for Health, to brokers, to carriers, to hospitals, to doctors, to departments, all of us working together in a public-private partnership. This is exciting. This is a great first step, and this is a draft. Your invitation is to make it all that. Bring it across the finish line, to make it better than we ever thought it could be, to set the standard for others to follow, and to be the pioneering state that we have always been and will continue to be. So with that, we'll open it up to some questions.
Very quickly before, well, yeah, go ahead and clap. That was, yeah, so just, we did initially say that we were going to shut the comment period off at the 21st. We've now extended that to the 25th. That's what's in the draft report, but wanted to make sure that everybody understood that it is going to be through that week of the 21st. So, questions?
Earlier is better. Earlier is better.
So I have the mic to make sure we get your questions, comments addressed, answered. I just note there's almost 100 people in the room, plus we have folks online that we'll be hearing from as well. So just keep that in mind as you share your thoughts, and just let me come on over.
Hi, thanks very much for this work. The goal is affordability. You could have made it more affordable if you didn't pay the brokers and you didn't let the insurance companies add 15% admin costs. So why did you include those costs in your plan?
So I'll start and Kim can jump in. So two things. With the brokers, so the broker community is an important, vital part of explaining to people what it is that they're purchasing. So we need to be able to actually compensate the broker community in a way that actually allows them to spend time with the individual market and explain to folks the ins and the outs of what it is, the product itself. Kim touched on it, and she's going to jump in and do a better job of explaining the kind of the administrative costs of that 15%. Right? If we didn't have the insurance companies in the mix with that 15%, we would have to do that at the state level in some way, whether that was a Medicaid buy-in or some other vehicle. That 15% would still be in play, or a portion of that 15% would still be in play. And most importantly, and I really want to stress this point, that if it wasn't for the insurance companies carrying the risk, which is huge, then we would have to carry the risk as the state. So that bad flu season, when we don't have enough premium coming in the door to actually pay our bills, the state has to actually make up for that difference. So that's really the 15%. But
Yeah, I'll add a few things. Somebody has to answer the phone. Somebody has to pay the claim. Somebody has to take the risk. The risk on average is a standard. To pay for it, that is about 3%. Somebody has to pay the taxes that come back to the state. That has to be in that retention. Somebody has to file rates and be reviewed. Somebody has to set those rates. Those are underwriters. There is a wealth of tasks that have to go on in order to run a health plan. Somebody has to do that. We chose in this model, ladies and gentlemen, T.R. Reed, Tom, to make sure that we brought together in a public-private partnership the strengths of the industry, that we didn't try to take Medicaid and take what are amazing strengths that take care of the most vulnerable and set it up and build something and start from a point of weakness and try to just catch up with the rest of the industry that was already there. To us on this committee and all that participated, we got to the right place. It would have been taking somebody that didn't have the strengths, trying to build to match somebody that's already there. And that was the decision that we made. But we appreciate that view. It was a common view, and we appreciate your valued contributions to the process, Tom.
Great. And if I can ask for the folks asking the questions to stand up and say who you are, and if you're representing anybody, share that as well. Thank you.
Jonathan Ward, retired cardiologist. Thank you for your business contributions, but I keep feeling there's the cart before the horse. The card is well described in affordability in terms of the hospital chains, the insurance companies, the profit from industry. But the driver of all of this, in my mind, 40% of this cost is the people ordering the tests, the procedures, the physicians, the providers. I'd like to hear more discussion about eliminating 40% of waste, inappropriate care, dangerous care that starts with the providers. And by the way, I'm one of those who have profited from the system in the past and now have very little vested interest in making this a better, a true system. But starting with the horse, with more emphasis on cost related to the physicians, and I'd like to hear more discussion on that with the commission in the future.
John, thank you. And thank you for your service and taking care of patients. And your transparency. That's where change starts. Thank you for your transparency. So because something isn't in this bill, this draft proposal, doesn't mean it isn't on a concurrent pathway and being addressed. So we didn't address things that were already being addressed and that we have massive collaboration going towards it. So let me give you some areas of amazing collaboration to address your issues. John Bartholomew, our CFO at Healthcare Policy and Financing, has been working for more than 3 years to bring Prometheus up and running. Prometheus is a tool that identifies potentially avoidable costs and potentially avoidable complications. We have provided that tool for free to hospitals and trying to find a pathway to get it to doctors. On the Medicaid side, we provided it to what's called our regional accountable entities. There are care management arms, if you will, in Medicaid. But all of the hospitals have been given that for free, and all have been trained on it. That tool allows them to see where they have opportunities for removing waste from the system and avoidable cost. So an avoidable cost might be when they compare themselves to their neighbors, they see that this billing for this one area that they're doing all the time, nobody else is doing. That's a potentially avoidable cost, and they realize they have inefficiencies in the way they're delivering that care. An avoidable complication would be potentially an orthopedic surgical unit that realizes they have more readmissions than others around them, and they have a quality problem. That tool, which costs us millions to develop, is now out in the market to address complications. We've also got some new tools that are emerging that get for care that has low value, so low value care that we're going to provide out. On the hospital provider fee, now called the Chase fee that we talked about, we're in wonderful collaboration with the Hospital Association to how to turn that from just making up for a shortfall of Medicaid, but rewarding the hospitals for changing in a way that's transformative, hospital transformation program. And those areas have quality metrics that we're seeking, and also ask the providers to go into areas where we have lower access, which we'll touch on in a minute. But there are hospital transformation program that's moving forward. There is the entire Prometheus work stream that's moving forward, and then there's a general fraud and abuse that's going on across the industry that we can spend a little bit more time. But these other 3 weeks are here for you to bring forward and say, I'd like to see this in addition. To complement and end with, we spent some time yesterday with both the Colorado Hospital Association and the Colorado Medical Society, and we challenged them to step up on the Medical Society to say to bring the things to the table that you can do to be part of the solution, especially in the area of empowering physicians to be able to better control cost and quality. And we are eager to know what they come forward with, because now that we've got a foundation, now we can refine. It's a perfect opportunity to address that area as you've highlighted.
So
Cool.
3 quick points to build on that. So there's 2 parts in the recommendation now that really kind of are structured to do exactly what you were just talking about, Doctor. First is a standardized benefit design, so that we're standardizing benefits so that we're putting the high value care up front. But then on top of that is the value-based insurance design, right? And that's what exactly Kim was talking about, that we've challenged CMS, the Medical Society, to come forward with and help us build out. But that's exactly what the advisory board is going to be for as well. So that we, as we go, as Kim said, that we can continue to improvise and improve as we move forward with this plan. The last piece, as Kim was talking about with concurrent pathways, the primary care bill from last year. The primary care bill from last year is designed so that we actually spend money in the right place at the right time, and we build a comprehensive primary care system in the state in order to really accomplish, I think, what your ultimate goal is.
And on the Prometheus tool, hospitals can see all the way down to the provider's behavior and patterns, so they can sit with a provider and coach them and say, you are out of line with your peers, and there's opportunity for you to be more efficient, so those extras are not going on as a standard going forward, which is an amazing thing for our state to have now. Thank you.
Thank you. Billy Wynn with Direct Health PBC, Mike and Kim. Thank you so much for the detailed proposal. You clearly had an incredibly tight time frame to produce the level of detail and thoughtfulness that you have, so just kudos to you and thank you for what you've put out in the time this morning. A lot of questions. I just want to focus on one thing though for now, which is the 175 to 225% reimbursement setting that you've proposed. Do you foresee that being an average across the hospital setting, or a cap that each service would have to be reimbursed underneath? And would that be, do you foresee it being, the same nationwide, statewide, or, that's pretty bad, sorry about that, or to potentially vary by county and rating area? And then last of the question is, you mentioned publication of the rates, and so would you publish kind of the top line guidance, or would carriers be required to publish the rates that they have with their provider partners within their network? Thank you.
So I'm probably not going to remember all three of them, but I'll do my best. So let me start with the statewide aspect. What we talked about and what we've committed ourselves to is to make sure that we are protecting our rural hospitals. So there is a recognition that whatever the set rate is will probably have some fluctuation, maybe by coverage area, maybe by some other metric. But that's one of the things that we're looking for over the next 2.5 weeks. On the average question, is it an average or is it going to be a ceiling? I think where our heads are at right now is that we want this to be an average that the carriers that can then build a network around. And then as part of their rate filing, they would justify to us that they actually do fit into that 175, 200, 225 metric. But again, that's something that we want to hear from folks over the next 2.5 weeks. And what was the third question? So yeah, I think there's going to be a component of this that one of the things that the consumer groups are adamant about is that we build more transparency through this product. So that is absolutely going to be a part of the equation.
So I'll just add color. All healthcare is local. In the alliance model that Commissioner Conway has established, if we publish the rates for those hospitals in that community, the employers can negotiate for those same rates. So if we have transparency around those rates, it allows everybody to understand. I also want to recognize that even within the same systems, on the Front Range, one of the systems that's partnered with Kaiser has rates that are below where we're asking. But in the Grand Junction area, the rates are 400% of Medicare. So even within the own systems, but again, part of this is multi-year approach. All healthcare is local, protect our rules, and allow the hospitals time to change and to come back and say, this is how we can get there. I have confidence. We have hospital CEOs standing up all over the state saying, I want to be part of the solution. But we need to give them time to deal with their executive leadership and to figure out how they come back and say, this is how we can do that. And it's important to give the industry flexibility and maneuverability to figure out how to be part of the solution. We want to do that.
Hi, I'm Jackie from Denver Health. So I really appreciate all the work that you both have done. We have tried to be good partners with you on this. I think this goes far beyond what the legislature intended in the innovation and the way that it's thinking about it, and I think that is wonderful. You have both said that you want to protect your rural and critical access hospitals. Can you make that promise that you will also protect your safety net as Denver Health?
I was on the phone last night with Robin and Peg at 5 o'clock. So we are eager to have for those of you who don't know, Robin is the CEO and Peg's the CFO. Your partnership with Medicaid, there are no words to describe how important it is. All healthcare is local, but there's also these, oddity providers that provide these critical services and show up in odd ways. Jen Dell's in the room, she's CEO of Craig Hospital. It's a very different hospital, right? Denver Health is a very different hospital. Yes, you have our commitment to recognize the difference in the hospitals, and that's why this 3-week period is so important. So people rise up with a passion to say, I will be part of the solution, and I'm confident that Denver Health will rise up with that message, but we need to give them time to figure out how. Now that we've given them some facts to chew on and to think about, now they can take the time to figure out how that presents itself. But you have our commitment to be in partnership.
Can I just, a real follow-up question? Sorry, I know, Commissioner, you're going to say something. But so I think then moving on to that fact piece is what will be really fascinating to look at is, Commissioner, when you're talking about insurance carriers mandating that they provide the public option unless they are too small, what kind of that small number looks like being a health plan ourselves. That's going to be really interesting. And then when you're looking at the pharmaceutical rebates, if that overlays at all with 340B, how that's going to work. Because we do some really good things with our 340B savings that we wouldn't want to see go away. So I think as we work to get you useful and effective comments, those are some other things that I think we're going to have a bigger picture as we all work through. But I really do, I appreciate the collaboration that has occurred and the collaboration that will occur. So thank you.
Yeah, so I was just going to say ditto to what Kim said earlier, but I think the 340B piece is an interesting component that we'll have to talk through. Kim's obviously
the
very well-versed.
340B doesn't have a rebate. It's an alternative to a rebate,
Right.
so I don't think it would impact it at all. Also, this is commercial space entirely. The passing through is only relative to commercial rebates and other compensation from manufacturers relative to the individual space, and then as we move on to the small employer space, relative to that, it should have no bearing whatsoever on the Medicaid space. Yeah, and we can have further dialogue on that. And relative to your size, that's why it says to be determined, so let's have good dialogue on that. And you know, Denver Health is this area where Denver Health is. It's not sitting in Grand Junction or sitting in the Northeast. It is where it is, so good dialogue and collaboration
Right.
on that.
Yep.
Hi, Adela Flores-Brennan with the Colorado Consumer Health Initiative. Thank you very much for this proposal. I think it is looking really good, and I appreciate the comprehensive look at affordability as well as the accountability and transparency mechanisms that you're envisioning. I have a couple of questions. One about what you're thinking about with respect to the value-based insurance design and whether you have ideas there yet and how we can implement VBID with due consideration given to consumer protections. And then also, we just wanted to know a little bit more about the pass-through of the pharmacy rebates and how that's going to be operationalized and how we can, in the interest of transparency, see that happening.
You want to take the value-based insurance design? I'll take the pass-through.
Sure.
You can do, you want the pass-through?
Yes,
Okay, go for the pass-through.
I'll do the pass-through. I'll take the value-based. See how this collaboration is working? So on the pass-through, we have met with advocates, and I don't think there's consensus on the how. Where there's consensus, or where it ultimately ends up, where there's consensus is that it has to move through the PBMs and the insurance companies. We have, with the interests of the purchasers, pretty much 100% consensus on that. Where we don't fully have consensus as does it go all the way to the consumer, or does it go to the reduction in the policy. Let's say that we're eager to have your feedback. As we've heard, even within your own advocate organizations, we don't have full consensus. So my specific preference would be to lower the price of the policy for the individual market, because if we pull the consumers into that, we could have an adverse incentive where a misaligned incentive means that individuals similar to a manufacturer says, hi consumer, I'm going to give you this coupon so you don't have any out-of-pocket costs for this expensive drug, but I'm going to give you an out-of-pocket cost in this less expensive drug where I make less profits and it's less attractive to me as a manufacturer. So we want to make sure we balance those things, that we don't have misaligned incentives back down to the consumer level. So my preference in full transparency is to offset the cost of the individual policy. But that's why we're in a 3-week period of let's have good dialogue.
And Adela, to speak, I think, to the operational aspect of the question, a number of the insurance companies currently actually are passing the entirety of it through now. So it's not operationally a problem, I don't think. I think what becomes the key is to make sure that we have the tools between us to actually make sure that we are regulating that effectively to actually see that it is being passed through, whether it's to premium or to cost shares. And that's the key component on the operational from my standpoint. On the value-based insurance design, I think Kim really touched on what we're thinking about with the value-based insurance design in our presentation and what we've had conversations with CMS about. But to touch on your concern about making sure that we aren't creating a value-based insurance design that is going to in some way unintentionally harm consumers, there's 2 points of that, right? There's the standardized benefit design, and I hate to keep coming back to that, but I think that is going to be an incredibly valuable piece of this puzzle. That will allow us to make sure that we are putting a product together that has real benefit and real value to consumers. The other component of what we're talking about is the advisory board, right? The whole intent of the advisory board is to make sure that we're not doing what you're concerned about, that we're not creating a system that is unintentionally harming people. That's why your organization and the consumer advocates just in general are going to be a key component of that advisory board.
Hi there, Amanda Massey with the Colorado Association of Health Plans. I just had 2 clarifying questions for you. So on the first, you mentioned through the proposal that we could see a rate reduction of 9 to 18% under this proposal. Does that include the rate reduction under the reinsurance program, or is that on top of the rate reduction for the reinsurance program?
That would be on top.
On top of, okay. And my second question for you is the reinsurance program. Do you see that that continuing once the public option or the state option is in place, or will this be a bridge to the public option?
No, we see that continuing.
Hi, Claire Brockbank with Segway Consulting, and I'd like to echo what everybody has said about congratulating you. This was a marathon in a sprint time, so well done. The question I have is we think about those 22 counties with only one carrier. Many of them are spread throughout the state. And so as you look at modeling out what plans, what carriers may need to come in, how will you make sure that they may decide to offer, but that they're actually in those 22 counties so that it's, I believe it's Anthem that's really made the commitment in those, most of those 22 counties, maybe not all of them, but how are you looking at actually bringing more into those single carrier counties?
So we're silent on that in the report, and we're intentionally silent because we want to hear from you all about how we should do that over the next 2.5 weeks. The intent is by bringing more carriers into the marketplace that they will spread out, but if that isn't going to be successful, then we have to come up with a different solution, right? Whether that's a mandate of some kind to go into the 22 counties. And remember, it's not just about these 22 counties. It's about the fact that we have a problem, and that problem ebbs and it flows, right? We have up in the northeast corner, for the first time next year, we will be down to 1 carrier counties. That's never happened up there before because Friday Health Plans has always been there, but they won't be there any longer. So this is something that we can't always foresee how this problem is going to arise. So whatever the solution is that we're putting in place has to account for that. So again, one of the things that we're going to be asking for is your thoughts over the next 2.5 weeks on that point.
But we also need the carriers to step up themselves.
Correct.
So again, in the same way that we're asking and we're providing grace and maneuverability for the hospitals and physicians, we want to invite the carriers to come up with their solutions in partnership, in public-private partnership, so that we aren't just saying this is the way it's going to be. So as Denver Health raised and said, whoa, I'm only in this section, Kaiser might say the same thing. My model is only right here. Let them come up with, together through the Colorado Provider Associate, help me. CAP, thank you. Through Amanda, it's through Amanda. That they can come back with us with some good options for us to consider.
And that's exactly right. And keep in mind too that we're taking a huge piece of the problem off of their shoulders when we're saying that we're going to be effectively negotiating their rates with the hospitals.
Good morning, Catherine Mulready with the Colorado Hospital Association. So you touched on it just a little bit, Mike, and I want to kind of build on Billy's question and some of the comments that this will be stepwise with some grace and maneuverability. Can you just talk a little bit more about kind of operationalizing this rate setting component? Is this a negotiable range? Is it ratcheting down over time? What's really the vision for how that looks? And I think I'd also just like to call out, while I appreciate some of the data that was shared today, we're talking about a statewide public option, and a lot of the data that was shared today is about Denver area hospitals. I think another data point to provide a little context about the variability of profitability among the hospital industry, we represent 110 hospitals and health systems, is where we've got, and I do greatly appreciate the commitment to fiercely protect rural. But even outside of rural, we have 21 hospitals, again, non-rural, that fail to meet sustainable margins over time in our last kind of cut of data. Certainly, Jackie, I think, acknowledged that Denver Health is one of those, but there's 20 others as well. And so certainly commit and continue to commit to fiercely protect rural hospitals, but this is about more than just rural. It's about more than just Denver. It's really about fiercely protecting access to care statewide. So rate setting, I think, is certainly the biggest component that we're concerned about, but would love to hear kind of how you foresee that working.
So I'll start, and then Kim can chime in too. So to your two questions, the answer to both are yes. So yes, it is going to be something that we are, to use your term, ratcheting down over time. We do want to, as Kim has said a few times throughout the presentation, make sure that we're doing this in a thoughtful way. So that includes not on January 1st, 2022, flipping the switch and saying it's 175% of Medicare. It's building over time. And there is going to be, right, there is a negotiation aspect of all of this. I mean, this is, as we've said a few times, this is a draft. So this is the time to have these discussions about where we think it actually makes sense to do all of these things. But keep in mind, too, that what we said is that where we are right now is that this is likely going to be something where we're putting in a metric that we expect and that we're going to demand the insurance companies to build a network around. So there will be a negotiation aspect that comes into play there, too. So the enforcement mechanism will be the rate filing. Right, so just like the rate filing works now, but we will enhance the rate filings that the insurance companies have to go through.
Your question was, what's the enforcement on the providers? And our agencies are confident we have enforcement on providers for that process. So we would rather invite you to the table than talk about enforcement, because we want this to be a collaborative effort, and we invite you to collaborate. And thank you for that.
Oh, sorry, I was just going to make sure I can run back over there with a microphone, but we have people joining us remotely, so wherever we can speak into the mic, it's better for the audience.
Yep.
Thank you, Brad Niederman, Colorado State Association of Health Underwriters. I think we're all here in this room because we do want to increase access and lower costs, and so thank you very much for all the work. Couple quick questions. Number one, just to clarify, is this available on exchange only or both on and off?
Both.
Both. Okay, thank you. And then the other concern that I kind of have and Cashew has is, the analogy of squeezing the balloon. If we're reducing reimbursement rates over here, is it going to then cost shift into the other markets? And I know you had said you're going to monitor the large group market. I would also ask that we're looking at small individual and small group market as well, because if reimbursement rates are going to come lower from over here, the providers, the hospitals, they're going to want to make that money up somewhere.
Sure. So I think a couple things in response to that. Keep in mind that a key component of what we're proposing here is that we do roll this into the small group market in a relatively short period of time. I mean, the ACA took 4 years to stand up. We're going to stand the first piece of this up in about 1.5 years, likely. And then after that, probably 2 or 3 years after that is when we're going to push this into the small group market. That's pretty fast. But most importantly, right, what I want to make sure that we're talking through is that with the purchasing alliance model, with all of the transparency that we're going to be putting into this marketplace, small group is a key component of the purchasing alliances too. So we want to encourage employers to join that and join together so that they have the ability to get to this place on their own without us necessarily even having to put the product into the small group market.
If I could add to that, there's an opportunity for a best practice that we can roll out. So Grand Junction's employer chamber has stepped up, and together we are meeting with the employers of that chamber on the 23rd of October. And we have a process of here's the affordability roadmap for the state, which they have customized in that community. Then how do the employers step up and be part of the process? So Anna will be presenting on how they use the reports from Civic. And Michael will be presenting on how does the Alliance program work. John will be presenting on the financials and the current reimbursements in the system. I'll be presenting on what is the affordability roadmap and how do they step up and what is their invitation to engage. Our pharmacy lead will be presenting on here's the pharmacy report of what drives costs and here's the solutions for employers. Here's what you're negotiating for on pharmacy. As John describes, here's what you're negotiating for on hospital. As Mike describes, here's how you negotiate, and Claire and Anna describe, here's the reports you can get out to negotiate. That's a best practice that we can move from community to community to community to community to empower employers to help be part of the solution, to prevent the cost shift, but also to drive the rates where they know they should be based on transparent information and partnership and collaboration with the hospitals in the system. We're very excited about that. It's not a pipe dream. It's this month rolling out.
Good morning, Tammy Niederman, consumer. I know currently for the carriers, I think it's about 3.5% to do business with Connect for Health for the ACA compliant. Do we know what it's going to cost the carriers to submit the business or to run business through Connect for Health for this plan?
So it's our anticipation that that wouldn't change, that the 3.5% would still be in play.
So a separate 3.5%?
No, the
so
same.
Just
Yeah.
across the board?
Yep.
Okay.
It's just yet another product on the same,
Right.
should be the same. That's why we employed it.
Good morning, Melissa O.C., HCA Health and Hospitals. Can you talk a little bit about the legislation that you are both anticipating will need to be run in the next legislative session, please?
So I'll start, and Kim, you jump in. So at this point, it's not in our purview to really be talking about the legislation. That's a question for the sponsors that may be running it. Is what we were tasked to do was put a recommendation together and put that recommendation together by November 15th. And that's what we're going to achieve. Now, I think there are pieces of legislation that are likely going to be needed to come out of this, but we don't want to get, to use the analogy that somebody else, the doctor in the back used, which he's now left, we can't put the cart before the horse. So we need to make sure that we're doing this in the right way.
Ditto.
Hi, sorry, T.R. Reed again. I have 3 insurance questions. In the one carrier counties, you're going to require them to sell the plan. What if there are 3 carriers and none of them wants to sell the plan? Second, will this cover all providers, or will the insurers have their networks of providers? And third, do the insurers have to sell the product to anybody who wants to buy it?
So I think the first and the third, sir, kind of go hand in hand. The insurance companies will be mandated. Our recommendation is that they're mandated to actually offer this product. So if we have 3 insurance companies in that county, all 3 will be offering this product. And the same protections from the ACA apply to this product. So yes, they will have to. The second question was? So the carriers will be building their own networks. So the networks will still be in play. We talk about them a little bit differently. We talk about them with high value networks, but yes, the network building will still be a component of this.
We're going to take a couple questions from online.
So this question is from Peter Long. You have mentioned commitment to protecting rural and small margin hospitals. What protections will be in place to ensure sustainability of healthcare providers that operate on small margins or loss?
I'm sorry, I was just taking notes here. So I think those providers have to come to the table and say, this is where our pain points are. Because the only thing we're changing in the system is the reimbursements, relative to reimbursements, is the hospital, inpatient and outpatient in this draft proposal. So if there are other areas of vulnerability, for example, the behavioral health community would say, we need additional providers, we don't have enough capacity, and the pay isn't enough. The avenue to address that is the Behavioral Health Task Force. So if there are other providers that feel vulnerable, that want their issues to be heard in this proposal, we need that brought forward. That hasn't been part of the conversation in the stakeholder engagement through the 14 or the letters that have come out. So if there is specific interest, I'm glad to have conversation on what those specific providers are. Michael,
No, I think that's right. Yeah.
Do we have, oh, yep.
Thank you. Good morning. My name is Chris Brown. I'm Director of Research with the Common Sense Policy Roundtable. So our organization, along with the REMI Partnership, which includes Colorado Concern, Denver South Economic Development Partnership, Colorado Association of Realtors, and the Colorado Bankers Association, we really took the time, we put out a study about a month ago, really took the time to try to understand the potential dynamics of a state option and educate ourselves and try to educate the public on the various dynamics. It really appears that some of those elements that we uncovered and identified seem to be major tenets of part of this proposal, including the rate setting, including below market rates, including having insurance carriers sort of be compelled to provide this, including providers sort of being forced to or having to accept this. So it's, again, it sort of doesn't seem like much of an option at that point. I guess my question is, or where we really drew most of our concern from was related to, you showed the information related to the change in charity care and uncompensated care. In that same report, it shows an increase in undercompensated care after the expansion of Medicaid. In that same report, and the net effect has actually been a decrease in both undercompensated and uncompensated care. So we'll continue to digest this and try to understand what you guys have put out in the actuarial modeling. My question is, actually in this particular slide you've pulled up, as you looked across these other states, as you talked about trying to get to some sort of national average, I guess my question for this forum for you would be, as you looked at these other states, do they employ a state option as a mechanism, or do they employ any of these other elements that you guys have included in this proposal, including setting reimbursement rates and the sort of elements in the market that we just identified?
So let me start with the report that you touched on. So the reason why I went back to this slide is because the entirety of your report is based off of the premise that we would be reimbursing at 100% of Medicare. That's not the case, right? We're reimbursing directly in line with 175 to 225% with what the other states have done. So that's the first piece, and that's what Kim was talking about earlier. But on your question about what have other states done, the state of Washington has done something similar. There are other states that are looking at doing different ideas, putting different ideas forward, but we are effectively the second state to go down this path.
I would add to that the curve is going the wrong way. Our rural hospitals need more help, and our front range hospitals, many of them have the opportunity to be more helpful. So I think we're addressing through this draft proposal the opportunities in the system, and we're aware of your report, and I think I'll leave it at that.
No, you have to.
Hi, Dave Downs, Colorado Medical Society. I'm curious as to whether you anticipate much. Migration from large or small market into the individual market, if this is priced significantly below.
So we got that question a lot, Dr. Downs, in relation to the reinsurance program, because folks thought that if with the dramatic relief that we're providing to the individual market with the reinsurance program, that would happen. I don't think that it will. We're going to monitor whether that is occurring. The reason why I don't think it will is because it's such a huge benefit for people in the small group market to have that employer-based coverage, the same thing with the large employer market, and it's a competitive advantage for those employers to offer it as well. The other factor, right, is that if you are above that 400% of the federal poverty level, an 18% premium decrease does not going to any place close come to matching what your employer is going to provide in the employer-based coverage. So when you actually look at the way that the math plays out and you look at all of the reasons why employer-based coverage exists, I don't think that we will see the migration, but like I said, it's going to be something that we monitor.
But I think for those employees who work for a small employer who can't afford to provide benefits, it will provide needed relief. Billy.
Last question, Billy.
Can we just like hang out and chat? Like, you know, everybody can,
No,
people
we're
can
going
leave.
out,
Oh,
though.
sorry. So Billy went again, direct health. This is my last question. I just wanted to talk about the requirement that insurers participate if they have a certain market share, and just query if kind of the motivation for that, and maybe this is to the health plan folks. Or, you know, are you concerned that there would not be enough participation otherwise? Because I think, Mike, you alluded to the fact that this setting of rates is, I would think, generically speaking, very attractive to insurers. It is a significant portion of what they otherwise do in the market, and you're giving them some significant assistance. So just intuitively, I would wonder if getting participation would be that difficult, and if perhaps you might get a better state coverage option outcome if you think of it as more of a competitive, you know, process rather than having everyone required to participate. Plans are certainly invited to participate, and that they are required to give a little more in return for this benefit they're getting of the state assisting them with setting provider rates, and then have that be kind of the playing field for who gets to serve as a state coverage option. And you know, you might get a little bit better, more support for vulnerable communities and other kind of benefits that you might not otherwise see.
So I'll take the first stab at that, and then you jump in, Kim. So yes, I think that there are multiple ways that you can increase competition, right? And that's what one of the requirements of the bill is for us to increase competition. And the reason I say I think that there are multiple ways that you can increase competition, effectively what we did with the Peak Health Alliance up in Summit County, we increased competition in the individual market because Rocky came in and bid on that business in the individual market. So we recognize that there are lots of ways that we can go to achieve that. And I think that's what Kim was talking about earlier when she said we're expecting the carriers to step up and partner with us to solve for this problem. Again, not just the 22 counties, but the possibility of having counties with just one insurance carrier.
I think I would add that this is an opportunity to have that good dialogue, but when we create a solution like this, we need to look 5 years, 10 years, and make sure we achieve the vision of the bill, which is let's really answer the call from consumers, really answer the call from small employers, and ask the industry of how we ensure the sustainability of all sides and access from all sides going forward. And so we're inviting the insurance companies to participate. But some along the way have said, I really only want to do this right here. We would ask from a higher calling that this is a pretty awesome state to do business with. And we want our carriers here, and we appreciate it. And I've been very complimentary to Commissioner Conway of the stability in the individual market. But to ask the insurers to, sometimes you have to step up to do more than what you would have just done because you wanted to, because it was easiest. Perhaps we can rise to a higher level to do what is best. All of us together, what is best. And asking them to compete in an area, that's not really too much to ask, but to ask them to come up with the how. So we're not mandating the how, that they come up with the creative way of the how. Again, in the best interest of Kaiser doesn't have a model there, or Denver Health doesn't have a model. Let's let them be creative, and then let's see where that takes us by November 15th. And that's an open invitation, Amanda, and you know that.
Thank you. My name is Annalise, and I'm newly with Colorado Concern. And I want to let you know that I'm interested in working with you, along with the rest of our CEO members, to try and make something like this work.
Thank
However,
you. Thank you.
Good, excellent.
Can we just give an applause? That's a big deal. That's a big deal.
Try and figure something out.
Thank you.
The biggest area of discomfort for me is the state coming in and saying or dictating the amount of profit that an industry is allowed to create in the state. And that just makes me fundamentally uncomfortable. Can you address that?
Sure, I would love to. So just to alleviate your concern, Colorado concern, we didn't do that. So what we did is, so there was an alternative. The ACA, which is obviously federal, not state, came in and said, carriers, we will dictate your ability in the aggregate to charge expenses and profit. And they set that 15% and 20% cap. We did not do that on the hospitals. We were very careful. We had alternatives that we could pursue. We didn't say, hospitals, your expenses have to stay at this and your profit has to stay in this. We stayed up at, could you please compete more effectively on your price that consumers and employers pay, And that price, can we please set it with the rest of the country? We're actually quite careful not to do that in respecting the industry of how do they get from here to there. We did not go at profits and expenses for the hospitals, nor did we do that in the physicians at all, or any other provider. Michael, anything to add for that?
Exactly right. Hi, Amber.
Good morning, Amber Burkhart with the Colorado Hospital Association. Thanks for being here today. I had a question with regards to the actuarial analysis. It talks a little bit about how in the final report you'll be producing a more comprehensive analysis. I was hoping you could touch on what is kind of missing in this analysis and what you hope to cover. And then talking a little bit about how some of the assumptions, if they turn out to be incorrect, there's a lot of uncertainty in the estimates that you're providing in the actuarial analysis. Will the full analysis talk a little bit more about what some of those assumptions are and what happens if they turn out to be incorrect?
Yeah, so I think a few things. As a couple people have alluded to, this was a sprint in the marathon time, and that was also true for our actuarial analysis, especially because we didn't actually give anything to our actuaries until we got through with the stakeholder process, because we didn't know what to give to the actuaries until we actually got through with the stakeholder process. So they had a very, very condensed amount of time to actually do the work that they've done. And that's why the actuarial report does have that clause in there, that statement in there, that we're going to have a more complete actuarial analysis that's part of the November 15th final report. That's reason number one. Reason number two is that we do want to have conversations, right? There's a lot of pieces that we've intentionally left open because we want to talk through where you all think that we have gotten this right, where you all think that we have gotten it wrong. And that'll also touch on the assumption piece, right? So as we build out this plan a little bit more comprehensively over the next 2.5 weeks, it will give us the opportunity to engage with our actuarials, with Wakely, to actually make sure that we've answered some of those questions too.
Hi, Ethan Lovell, consumer. So I'm thinking about what you're asking of the various constituencies, and it seems that you want the hospitals to partner with you and do business at a price point where they may not be as comfortable as they once were historically. I'm wondering if there are tools that you're working on either as a part of this or in parallel, and you were kind of hinting at a parallel track where you're working on other things, tools that will enable the hospitals to purchase more effectively or to negotiate more effectively such that they can work to bring their cost structure to a more efficient point.
So I'll take the first crack at that. So we have been in conversations with our rural hospitals who, you know, we owe them so much. They step up and try to be all things to all people in a community, but they can't purchase their prescription drugs that they have to provide at an affordable rate. They're small. They can't purchase everything from linens to everything else. So we are in dialogue about that and how we might be able to partner, knowing that there are funny rules around antitrust and where hospitals can step up and work together and where they can't. So we're exploring all of that. In fact, we have a call today at 11:30 with a big group of hospitals figuring out how to get from here to there. This as well as other pathways relative to specific of purchasing more effective. When we talk about rurals and other hospitals, you know, some of the big hospitals, they already have, say HCA, it's the biggest for-profit system in the country. It's out of Nashville, it has a whole bunch of hospitals, and they can work together. Centura just aligned with a huge system, right? They're now part of the largest not-for-profit system. University is pretty darn huge. It's really the smaller ones and the independents, so Boulder Community Hospital, Parkview, Denver Health, the ones that in the rurals, the critical access, that we can do a better job. So that is being explored in some detail to try to figure out how to best do that to help them and know that those conversations are ongoing. I think we're at a good place.
I think so too.
Okay, I'll start some closing comments, and then, so I'm going to start where we began, which is thank you. You have been incredibly impressive in your dialogue and your contributions to get 42 letters, to have every one of the 14 stakeholder meetings with outstanding dialogue. Thank you for your contributions. Invitation to be just as engaged in the next 2.5 weeks. The earlier the better, please, because we extended on your end, but nobody extended on our end. So earlier the better. Thank you to the bill sponsors, and I want to leave you with a vision and a pep talk. This is the pioneering state. You are all that. This is where people come to make difference and change. This is where entrepreneurs choose to live. This is where healthcare entrepreneurs choose to rise. We are all that. Bring your ideas and let's really make something special happen in this state in a public-private partnership like nobody's ever seen.
Yep, and just to build on that, going back to what I said at the front end of this, we really do have an incredibly unique opportunity right now in Colorado between a legislature that is motivated to get something done, between a governor that is motivated to get everything done, between people that are committed to working 20-hour days sometimes to make sure that we actually get these things accomplished. And to really just drive home the point that the eyes of the country really are on us. I mean, T.R. Reid is here, for Christ's sake. I mean, that's amazing. So anyways, it's really exciting, folks. I'm really excited. I hope you are too. We're going to continue the conversations for the next 2.5 weeks, but I promise you that after we put out this report on November 15th, the conversations will continue after that as well. Thanks, folks.
Thank you.